Good afternoon, everyone. Welcome to the Underserved Population Network. Today's session is Housing Issues Plaguing Seniors. And this is Misty Kevich, one of the RN project coordinators with HHQI. Also on our call today is Crystal Welch and Sharon Miller, other RN project coordinators. We also have Misty Dyke and Andrea Lefke with us today from our communications department. So we want to welcome all of you to the session, and let's go ahead and get started today. I thought we'd start with a few facts from AARP to kind of start to segue into our topic for today. There are over 19 million adults that are 50 or older living in either unaffordable or unsafe housing. And nearly 25% of these households have mortgages that are underwater. Well, when I read that term, I had no idea what underwater meant. Now, in the last month or so, I think a lot of states have felt a lot of their houses have been underwater because of the flooding issues. But what underwater means related to mortgages is that the mortgage is larger than the current value of the house. And foreclosures also continue to be at record highs for the seniors. Now, we're going to have Misty put up a polling question for you. If you'd go ahead and answer, how long does a senior have to wait for senior housing in your community? So go ahead and select 1 to 3 months, 4 to 8, 9 to 12 months, longer than a year, or I have no idea. And then go ahead and click the submit button. And we'll give you about another few seconds. Very good. And we're going to come back to those questions in just a minute, or the responses in just a minute. So we're going to go ahead and move to the next polling question, and Misty's going to put that up for you. Do you have an aging parent, grandparent, or an other relative that you have concerns about potential housing issues? Either you're dealing with it now, already seeing issues, not yet, but can foresee issues, or just not yet. Just another few seconds there. Great. And then as our results come in, I'm going to kind of share those with you because I'm pretty certain that on the first issue that we will probably, most of us are probably not going to have much of an idea as to how long it takes a senior to get those responses in. So let's just see what I get for here we go. For the first question, how long? About 38% said longer than a year, and 38% have no idea. So gone are those days that it would take 1 or 3 months to get a patient placed in some type of senior housing. And we're going to hear some of the reasons and talk about those in a little bit longer. So I'm not surprised. And the next polling question results. Great. Do you have an aging parent? And about half of you said not yet. And the rest of you are about a quarter of you not yet, but can foresee that. So as we continue, as we see our parents and grandparents aging, we are going to probably address some of these issues personally. Great. Thank you, Misty, for those questions for us. Now, most of us in school studied Maslow's hierarchy, knowing that our goal is to improve self-motivation, but there is the foundational levels that we must achieve first. So with the hierarchy, we start from those foundational needs and work upwards. So the foundational needs of physiological safety and moving all the way up to self-actualization. Now, how that factors in healthcare, in a lot of what we do in home care, is work on disease management, patient self-management. So to be able to achieve that and keep patients out of the hospital, keep them out of the emergency rooms, be able to live longer and stay at home where they want to be, we really have to basically start at the bottom and making sure that the lower levels of those physical requirements are met first. Even though we typically start working on disease management and self-management immediately, we really have to start thinking about some of those other levels and really asking the right questions beyond the basics when we go in to do our admission or readmission into a patient's home. You know, we talk about adequate food, but do we ask, are they on the SNAP program, which used to be the food stamp program? Are they using food bank? So many of our elderly seniors, especially our dual eligibles, rely on both of those as pretty much their entire food source because their dollars are being spent on housing and on utilities. Do they have safe water? We have issues in rural areas that they're using wells that may be contaminated, but also even in cities, and unfortunately even in West Virginia last year with the chemicals that were spilled into the rivers that affected the water source and continues to affect the water source in many of the communities in West Virginia, and that happens across the country. But are we also, what about the shelter and housing? Is it safe? Is it affordable? And that's going to be our focus today. But we also have to look at the heating and this time of the year with the cooling. Our temperatures have been in the 90s and 100s across most of the United States. We know this is when the deaths occur from the heat, and it's usually the elderly. But we need to find out, do they have fans? Do they have air conditioning? Do they have a backup plan for when the electric goes out? Do they know where to go? I thought it was interesting. One of the cities I saw on the news this morning or yesterday were allowing seniors to get on buses for free and ride around during the heat of the day in the air-conditioned buses. So we need to know those things and make sure there's a plan in place to take care of some of their physiological needs. So what they're, I had a slide here to talk about shelter. For some reason, it's not coming up right now for us. But we have to look at what kind of referrals can we make. Do we have people that are having trouble paying their rent? Can we get them some assistance, financial assistance, by doing a medical social worker referral? Do we have that transient population where they're not homeless, but they're moving from one couch to another couch? So what can we do in home care with those people to be able to care for their medical needs? We need to get as many emergency contact numbers, cell phones, that we might be able to figure out where that person is staying and helping them arrange transportation for follow-up because their location changes constantly. So great needs for social worker referrals, also therapy referrals, making sure that patients can get out to those transportations. So we're going to move to the next slide, and I'm actually going to have Crystal Welsh kind of tell us a little story or a little scenario that you may sound very familiar to, something that you might have heard about people and housing issues. So Crystal, are you with us? And you might have us on mute.
Okay, I did. Can you hear me?
Yes, we can.
All right. Well, yeah, ironically, I was speaking to a friend recently about her mother, and she was one of those that was on a waiting list for senior housing and was notified, even though they were somewhat prepared, you know, with the waiting list. It's some things you can't really prepare for enough, and she was notified that she was going to be able to get her senior housing. And although it's a good transition for her mother, she'll not have the responsibilities of maintaining her residence, but she is very fond of her cat, and that is such a pet for her and such a comfort for her, and so she's somewhat heartbroken. So there is an emotional side that Misty and I were talking about, and she's a widow. The cat is also older as well, and she and her husband had that cat together. But, you know, her pet brings a lot of comfort and company to her, and along with selling many of her possessions to move into her new housing, which is very much smaller than her home, and just not being able to bring her pet with her, you know, could just really make for an emotional time. And fortunately, her daughter will be able to take the cat, but her daughter's somewhat relieved, actually, because she's had some close calls with her mother falling and tripping, and so the cat usually hangs out around her feet. So her daughter, even though she's a little relieved that she's going to be taking her cat, she's offered actually to get her mother, well, her mother doesn't know this yet, but when she moves in, she's going to be getting her a betta fish, you know, something just to kind of help that transition. But I had just shared that story with Misty, just maybe to bring up, you know, one of the emotional things that seniors might be going through. So I just wanted to mention that on the call.
Thanks so much, Crystal. And the seniors, you know, first place, they're losing their independence in their home. So that is an emotional barrier that they have heavy on their heart, let alone thinking about a loss of having their pet, you know, not. Again, some places do allow pets, but most of the housing doesn't, probably not. So that is an issue, and if that is a barrier, then alternative housing needs to be looked at early on because they really want to take their pet with them. So just when we talk about the issues of housing problems, we need to think a lot deeper than what we currently do for home health, because we cannot work on disease management and really improve patient outcomes unless we know that the basic needs are filled. This should be something that is addressed across all settings, but we need to take that handoff and making sure we're the eyes and ears. Our clinicians that are in the home are able to see what really exists, not what that patient tells the doctor or what they tell the hospital that's at home. We find very much deplorable situations in the home, and I know where I had worked previously, we only did IVs if there was running water and a whole list of, you know, electricity, et cetera. And I had a nurse call once when I was a supervisor and said, does a hose running from the neighbor's house through a window into this trailer can constitute running water? And as you know, in home health, we really try to accommodate our patients where they are in the situations they are, and we make do with what we have. But we need to make sure it's safe, and it's safe for that person to exist in that home. And finding affordable housing is really a very significant issue. That's the reason for our call today, and I'm just so thrilled to have Robyn Stone with us today. Dr. Stone is a noted researcher and a leading international authority on aging and long-term care policy. She joined LeadingAge to establish and oversee the LeadingAge Center for Applied Research. I was thrilled when I was able to meet her back in January, actually, and listen to her present at a conference. And excellent presenter and excellent authority on the aging people, and especially with housing and the issues and barriers with that. Previously, Dr. Stone was the executive director of and chief operating officer of the International Longevity Center in the United States at New York, and she also worked for the Federal Agency of Healthcare Policy and Research. One of the interesting facts that I didn't know until recently is she also served as the White House Deputy Assistant Secretary for Disability, Aging, and Long-Term Care Policy, and as an acting Assistant Secretary for Aging in the U.S. Department of Health and Human Services under the Clinton administration. So that was very interesting. She is also a senior researcher has been a senior researcher at the National Centers for Health Services as well as Project Hope Center for Health Affairs. She holds a doctorate in public health from the University of California, Berkeley. And so with that, I'd like to go ahead and turn it over to Robyn.
Thank you very much, Misty, and I have been so looking forward to this. Home health is not only one of my favorite sectors, but it is, as many of you may know, the fastest growing sector of all of the long-term services and supports and post-acute environments. And what I want to talk to you about today is a little slice of aging in community and how home health agencies and home care agencies in particular can think about working with housing providers. And I start by talking about this reality of aging in community, where we always see this consistent preference for remaining at home. But there's really a lot of challenges to aging in place, and I think Misty did a really good job of talking about the physical barriers, certainly a growing financial barrier for many seniors, including the new cohorts of older adults coming in who are aging, who will not have some of the financial stability that many of this current cohort of elders have. We probably have seen the wealthiest group of elderly that we will see for any time in the near future. Post-2008 was really a bellwether for a lot of folks losing a lot of assets, including assets in their house. The other thing is that people who want to remain in their own homes are not necessarily always better off because of a loss of social connectedness and engagement. So what we've actually been talking about is really moving to aging in community as opposed to aging in place, and really sort of recognizing that wherever you are living, it is really important to age successfully. And one of those options for quite a few people is publicly subsidized housing. For the past 10 years, my group here at LeadingAge, which is a national association of aging services providers, many of whom are low-income senior housing providers, have been really looking at the potential for senior housing as a platform for effective and efficient delivery of services. And I'm going to talk a little bit about the potential there and how home health and home care might think about these partnerships. Unfortunately, we have a lack of affordable housing, so everything I'm going to talk to you about today is for existing seniors. As Misty was saying, we have a lot of people on waiting lists, and one of the things that all of us are going to have to think about in the future is how do we actually support new development of affordable housing options. But today we have over 2 million very low and modest income seniors who are living in these types of environments. Some of them are huge high-rises, others of them are very small entities. They're all in some way publicly subsidized. Many of the dollars coming through housing and urban development. There's also tax credits that are used to develop these kinds of programs. And there's typically subsidies for the rental piece of this, which is a really big chunk of change for a lot of seniors and why those subsidies are so important. We have been looking at the potential of housing plus services for low and modest income older adults. And we're really interested in the opportunity for these partnerships with different kinds of health and community-based entities. And in a number of the models that we've been looking at, home health has been very involved in the development of these service programs. So that's why I'm hoping that you might get jazzed from some of the things that I'm talking about today and figure out how you might partner in your own community. So to move to the next slide, which is not seeming to move. And can anybody help me move the slide to the next? Oh, there we go.
There you go.
Okay, so here's what the seniors in assisted housing today look like. Their median income is a little bit over $10,000. So we're talking about pretty poor folks. About 30% of them are 80 and over. You know, in the 1960s, these folks were pretty young, and a lot of these folks are aging in place. The median age of move-in is 70, with 1 out of 5 move-in of 80 and over. So the population in senior housing itself has aged, both in terms of those who are aging in their own apartments and those who are moving in. They're also very diverse. While across the country, a little over a half are white, that means the rest of them are not. And we have significant Hispanic, African American, and other populations. In many places that we do our work in, it's not unusual to have at least 5 or 6 different people of color, as well as different ethnic groups living in what we sort of think of as a Tower of Babel. And, you know, that becomes a real challenge particularly for home health agencies that are taking care of people in these buildings, is sort of how do you deal with these multiple populations, and thinking about the cultural competence that is required to address the needs of these various groups. Now let's see. Uh-oh, I just lost my slide.
Just a moment. I think Misty is taking care of something for us, so we'll be back in just a second.
Okay. Here we go.
Just give us a second. And
if you want to, do you need to be advancing it rather than myself? I can do it either way.
Misty, would you like to go ahead and advance them, or I think you're on mute.
I don't seem to have the arrow to advance on mine.
No, she has it right this moment. There must have been a technical issue. I was so enthralled in listening to you that I didn't realize. So
yes, we're good to go. I'm sorry, we're having technical issues. Just let me know when to advance the slide.
Okay, so let's take a look here at some data from a study that we have just finished at LeadingAge together with the Lewin group here in Washington, D.C. We were very lucky to get a contract with the Department of Health and Human Services and the Department of Housing and Urban Development so that we could actually look at who is living in these subsidized housing properties and what are their needs, particularly their health care needs. We linked HUD data with Medicare and Medicaid claims data for the years 2007 to 2009. And we were doing this for a number of reasons. We wanted to estimate the level of Part D subsidy enrollment. We wanted to look at the level of Medicaid enrollment in these buildings. And we also wanted to look at their Medicare and Medicaid utilization and payments relative to their peers who were living in the community surrounding them. So if we can move to the next slide. So here's the picture of housing and health. If you look at the Medicare per member per month, you can see that there's a big difference between the HUD-assisted Medicare beneficiaries and the unassisted Medicare beneficiaries. So on average, the per member per month payment is almost $1,500 for somebody living in publicly subsidized housing, as opposed to elders living in that same community. It's about 58% higher. And remember, these tend to be low-income communities in general where this housing is. So that's a big issue for us. We already know that these are expensive, what we call the more high utilizers. The other thing that's really important to see is that 70% of these folks who are living in HUD-assisted housing are dual eligibles. That means that these are places where there is great potential for intervention, particularly for any of you folks in home care or home health who are involved with either dual demonstrations or taking care of the dual population. This is where you're going to find a lot of these folks. And if you look at the proportion of these folks with 5 or more chronic conditions, you can see that the HUD-assisted duals are actually higher chronicity than even the duals who are living in the community. So 55% of them, of the duals living in HUD housing or publicly subsidized housing, have 5 or more chronic conditions relative to only 43% of the duals living in the community. So what does that tell us if we can move to the next slide? We've really got a very high-risk population living in senior housing. And this is just to show you the difference even between the HUD duals and the unassisted duals. These are people who are living in housing just in the community but not publicly subsidized. There's even a difference there between 1,222 and 1,054, a 16% difference. Similarly, if you look at the various healthcare utilization estimates, differences in acute stay, in hospital readmissions, significantly higher use of Medicare home health visits. Look at that, 30% difference, as well as differences in emergency room visits and physician office visits and ambulatory surgery center visits. So this is a population where we need to be paying attention and we need to be investing in terms of interventions that might make a difference for helping low-income folks in these types of settings, but also maybe helping to save Medicare and Medicaid dollars down the road. So if you can move to the next slide. This is the average Medicaid payment. Again, if you look at this for the duals population, for those living in HUD housing versus those living just in the community, they are 32% more expensive, and they are much more likely to be using personal care services, as well as DME and other home and community-based services. So this gives you a picture of these folks in your communities. I don't know how many of you right now are providing services to people in publicly subsidized housing, but we really think of these as the high-risk, super utilizer, great potential for better intervention by home care and home health agencies with the potential for really helping everybody and sort of creating a win-win. So if you turn to the next slide, just another discussion of the difference between the chronic conditions for the 65-year-old populations and overpopulations, and you can see the difference here between the HUD-assisted and the unassisted, significant differences in the chronicity of these folks. Next slide. So then what do we have today in our senior housing? And the importance, I think, for home health and home care agencies to understand this is because we believe that housing not only is a good platform for you all to be partnering, but there's also, in many places, an infrastructure. First of all, from a survey that we did of properties that were part of our database, the 2007 to 2009 database, we then went back and surveyed the housing properties themselves to find out what kind of services were available at these property sites. So 69% of these places have a service coordinator, which these service coordinators, typically they're funded by HUD. They may also be funded by grants or some operating budgets from some of these different places. These folks are usually a social worker or somebody trained in gerontology. A few of them that we have met in our case studies actually were former nursing assistants or home health aides who became service coordinators. And they are really there to help and coordinate the full range of services that Misty was talking to you about. So everything from getting people access to SNAP benefits, making sure they're on the Part D subsidy programs, making sure they're getting the LIHEAP energy assistance, as well as connecting them with the healthcare system, the local area agencies on aging, and the other community resources that are going to allow them to age successfully. So this is a very important role that these folks play in housing. At least a quarter of them have some type of, also have some type of activity coordinator, which we believe are very important in partnering with home care agencies because these folks are there to do things like organizing health education, exercise programs, Tai Chi, chronic disease self-management, all of the kinds of things that you are engaged in. This infrastructure in senior housing can help you do that. The nursing presence in senior housing is much less. In our study, only 13% of them had nurses. Now, and this is a nurse that at least has some dedicated time to the property. Typically, the nurses are doing wellness visits, health monitoring, some may be doing some medication management. But, you know, the presence of the service coordinator really is the strongest piece of the infrastructure that could be partnering with you. And if you can get me to the next slide. So here's the array of on-site services that are available to folks living in these environments. You can see that the biggest are social activities, which is really, really focused on social isolation and trying to get more social engagement. The second highest, however, 2/3 of the properties have health education available. And to me, this is a really important piece for you in terms of how you might dovetail with and work closely together with senior housing around health education and health screening. We also see that, about 1/3 have some type of congregate meal, so there's a nutrition piece to that, as well as exercise and fitness. Somewhat less of an on-site presence for personal care and some of these other pieces. The smallest being primary health care and mental health. We do have some examples of co-location of primary health care clinics, and for example, we have some models where home health organizations or local accountable care organizations or managed care organizations are actually sharing a nurse practitioner that is actually doing work as either primary care or as a liaison with the primary care providers. But again, for you is thinking about how does this housing and service system, how could you partner better with housing in your community to effectively serve a lot more people very efficiently? You've got a lot more potential for group health education. You've got a lot more potential for patient activation and ongoing compliance. You also have the potential to work with the service coordinator and other folks to actually follow up on the interventions that you are engaged in so that you don't have a bounce back to the hospital once somebody has come home and you have been involved in the home health visits. But how do you then make sure that people don't slide downhill? And that's where the service coordinator and that infrastructure can come in. So if you could move to the next slide. So why are we even thinking about housing plus services? Well, there's at least 3 things. One is that we have seen tremendous expansion of home and community-based services across the country. We're also seeing, both through the Affordable Care Act, all of the state efforts, all of the delivery reform efforts and payment reform efforts, with a serious focus on improving coordination and the integration of health and LTSS, long-term care services and supports. And finally, this very increased focus on the dual eligibles, particularly at the state level. These policy priorities really provide the opportunity for thinking about housing not only as shelter, which, as Misty said, is the lowest on the Maslow hierarchy. So shelter is essential, but then also thinking about this housing as a platform for more efficient and effective delivery. So if I could go to the next slide. So this is really bringing it all together. If you look at the population trends, we have this demographic, health, economic, and housing trends all pushing together for a desire for seniors to age in community. We have fair housing on the housing side that allows people who are qualified for publicly subsidized housing to move in, assuming that there's a unit available. And there's really few alternatives for these folks. So it's a voluntary to move in, but there's no options if you have to evict somebody. The only place that most of these lower income people could go would be either out on the street or possibly, if they qualified, into a Medicaid nursing home. So this puts a lot of pressure on housing to try to help people age successfully. They need partners like home health agencies to make that work. And then finally, the feds and the states are, as I said, looking at enhanced community options. They want to improve health outcomes, and let's face it, they're all looking at lower costs. They want to be able to bend the cost curve for the Medicare and the Medicaid program. So these are the synergies that are helping us to think about the advancement of these new models and strategies for trying to get to the most high-risk people, of whom we now see many of them are living in these publicly subsidized environments. So if you move to the next slide, I'll tell you a little bit about a Learning Collaborative pilot. For about 2 years, and this pilot just ended, we've had 12 teams of housing providers and healthcare, including one in Vermont that had a very strong partnership with the home health agencies in the state of Vermont, to develop strategies for linking affordable senior housing and services. And really the focus of this Learning Collaborative has been on housing health partnerships. How do we foster resident engagement? Because that, you know, I know for you all as home health providers, you've got to engage your patient or your client as well as the family. If they don't engage and they don't learn and they don't take on some self-management, you can't expect to be successful, and you are more and more going to be scrutinized for not only your delivery but the outcomes in terms of things like rehospitalizations and ER use and other kinds of untoward things that could happen. The other thing that we really talked about was resident assessment and outcome metrics. One of the things that senior housing has not done, remember this is not assisted living and it's not a nursing home, it's an independent living, they don't really do assessments on their residents. And they didn't really even think that they could because of fair housing. But what we have found is there's nothing that stops housing from actually understanding who their residents are on a voluntary basis. And so many of our housing providers who want to do these kinds of partnerships are beginning to do much more assessment and oversight of their residents. We think that those data are going to be very helpful to home health agencies who may be partnering with housing to try to figure out where are the best interventions for individuals but also for groups. And then finally, really thinking about what is this enhanced service coordinator role. For many years, the service coordinator was sort of on her own in these housing properties. But how do you work more closely with home health agencies, for example? What is the relationship between nurses and service coordinators? In many of our cases, the home health agencies become the contracting agency for getting the wellness nurses who are actually working in these publicly subsidized environments. So there's a lot of opportunity for interaction between home health and housing. If we turn to the next slide, I'm going to close with a few examples of programs that we're actually looking at. Probably the most mature program has been the care coordination model that's in senior housing in Vermont, called the Supports and Services at Home Program Evaluation. We are studying this demonstration. There are multiple properties, including public housing authorities, as well as HUD 202s and different kinds of financing arrangements. But the crux of this is, and now actually this program has expanded to 80 properties across the entire state. So 80 housing organizations are part of this program statewide. Each property has an interdisciplinary team of a housing-based staff that includes a stash coordinator and a part-time wellness nurse for each 100 residents. And then they work with the network of community-based providers who, in the case of Vermont, are the home health agencies, the area agencies on aging, the mental health providers, because there's a lot of chronic mental illness and depression in many of these places. And they are also then linked in with the state's health reform effort. So in the state of Vermont, the regions have been broken up into 5 medical homes that are supported by community health teams. And SASH, the housing coordinator wellness nurse team, is now an extender of those community health teams. So by doing this, primary care can actually has a window into where these low-income people are living. And the statewide expansion has been supported through a Medicare demonstration program. And if you move to the next slide, you can see that we have a 3-year evaluation of this program. Medicare has been paying about $70,000 a year for a SASH wellness nurse partnership. And it's based on a service coordinator already being in the building. So these dollars go to actually enhancing that coordination effort. we looked at what happened to the SASH participants, and we compared them with folks who were not in SASH in Vermont. We also had another comparison group in New York. And our early results, and this is pretty astonishing for the first-year results, is that SASH is actually bending that cost curve. We've seen that the growth in total Medicare expenditures is lower for SASH participants than for either of the two comparison groups. This has been incredibly promising and is making CMS and the states start to look at housing as a potential solution to some of this care coordination and integration, which is why I think home health really needs to start paying attention to partnerships in your local communities. So if we could move to the next slide. Another example is Presbyterian Senior Living, which is a low-income housing properties in central PA. They have been partnering with Pinnacle Health, which is a new ACO in the Harrisburg area. And basically, they've been piloting a care navigation program where they have a weekly on-site clinic that's staffed by a geriatrician, an RN, and a social worker who works with the service coordinator. And their focus has been really on these high utilizers. They're able to get their data from the health system, flag the high utilizers, and then begin to focus on how do they keep those people out of the hospital and out of high-risk situations, and to coordinate with the primary care physician or serve as the PCP if one is needed. They do a lot of work around medication reconciliation, looking at home safety to avoid falls, and the whole area of health education. So if I can move to the next slide. These are just data from Pinnacle between January of 12 through January of 13. You can see that the ER visits and the inpatient visits went substantially down, and that's really exciting for a hospital or ACO system that is really trying to make a difference in their hospitalization rates. And finally, if you can move to the next slide, the final example that we've been looking at is a very different model called Housing with Services in Portland, Oregon. This is really a formal consortium of housing and services providers, and they have actually formed an LLC. They have a managed care plan. They have an area agency on aging. They have 11 housing providers. They have a home health agency, a mental health clinic, all working together to actually support these seniors who are living in low-income housing. And ultimately, they are experimenting with the state to try to get the health providers and the insurers, because a lot of their health care now is going through managed care, to provide a per member per month payment. That's their ultimate goal. So very quickly, the next slide. I just wanted to let you know that we have a guide that we have done for how housing can work with health care. I think this is very relevant for you as home health providers. You can get access to it on our website, which is www.leadingage.org/housinghealth. We put this together with money from the AARP Foundation, and we have people using it all over the country to help them partner. We also have a return on investment template so you can understand exactly what the business model is. So, you know, please avail yourselves of this toolkit because we really want the folks in communities to be using them. And just to wrap up, if you can move to the next slide, and the next one. Next slide, yep. I wanted to leave you by also talking about the fact that it's not just in senior housing in the buildings themselves, but it's also thinking about how you partner with naturally occurring retirement communities, otherwise known as NORCs. And for those of you who do not know what these NORCs are, they're really just large concentrations of elders living in a particular community. And, you know, that can be either vertical or horizontal. You can think about it as partnerships with local social service agencies, healthcare, and others. Probably the most ambitious NORC was the ones that were done by the United Hospital Fund in New York City because they have tremendous density with many, many, many blocks of seniors who are living in very close proximity. And to me, the NORCs are a natural for partnerships with home health agencies. Half of them are in urban areas, but it's also interesting to know that 42% of them are in suburban, and there are even a few in rural communities. So please take advantage and begin to know the NORCs in your communities so that you can be partnering with them and trying to be part of the healthcare solution. So I'm going to stop there and turn it back over to Misty.
Oh, thank you so much, Robyn. That was great information. So if you have questions, go ahead and put those into the Q&A or into the chat, and we will facilitate those. As we're waiting for some questions, I'm going to throw out a few comments to start with, or some points to continue on that Robyn has already initiated. I think having Pinnacle, which was a great example of an ACO, this is the advent. We're seeing changes in payment structures and models, and we have been over the last few years. We know that CMS has a directive that in the next 2 years, 2+ years, that all hospitals will be on about a 50% different payment model than the current system. So we're going to see more ACOs, more bundled payments, more payment models and structures that provides great opportunity for our experience in home health to be partners in keeping the patients at home or aging in their community and trying to provide services. So I think this is, the writing is not even just on the wall. It's there. We know it's going to continue. We're going to see new models of care, and to survive and to prosper in this environment and be able to improve outcomes, we really need to work in partnerships across all settings, but a great opportunity. And another key point, or several key points that, Robyn, you made, is constantly about making partnerships with the housing authorities. And some thoughts went through my mind when you were talking about that is it's kind of a win-win. We used to in home health, and I will date myself, it's been 35 years, I believe, that I've been in home health and home care in some fashion, but we used to go out to senior centers and to senior high-rises and whatever housing apartments they were, and we did free blood pressure screenings, we did, blood glucose screenings, we did health education, but in the times of cutbacks, most agencies cut those services out, so we lost that connection to those physical buildings and residents, but let alone the departments, the area on aging and the housing departments. But what great opportunities for us to work even at a board or committee level, because we can learn more about what is offered, the systems, but we have a lot to offer. We have expertise of working with clients in the home. And another great opportunities, we have physical therapists and occupational therapists that every day deal with barriers and issues. And as these housing authorities are looking for building new buildings and new communities, what great assets would be to provide, being able to resource and have some therapists provide some insight on building and getting around and being able to age in place in those settings as well. So those were a few thoughts. Let's see if we have any Q&As. Nothing yet. So we don't have any yet coming in. So I think the models are great. I will tell you, I have heard a speaker from Vermont on the SASH program about 1.5 years ago when it was first starting, and I was so excited. So thank you, Robyn, for sharing their successes already. That was exciting.
Misty, let me just speak a little bit to your comments. The first thing I wanted to say is that we do a lot of work with the large public housing authorities and with their association. They have taken on aging as their major focus for the next couple of years, and there is going to be, I think, a lot of experimentation around partnerships with public housing authorities in communities around the country. You know, in the old days, you're right, I mean, the community nursing, it was not unusual to be going in and doing all kinds of services pro bono. I think in this new age of payment reform, thinking about how home health begins to partner with housing as part of a bundled payment or as part of a mechanism for being able to stretch resources to be more efficient, and also, again, as to keeping these high utilizers out of much more restrictive or expensive environments, I think is going to be to the benefit of the home health agencies that are creative in their communities. So the other thing that I was going to say is that we have seen the evolution of the SASH model in Vermont. There was a little bit of tension between home health agencies and the SASH program in the beginning, because the home health agencies in Vermont are responsible for all the home care, all the waiver programs, the Medicaid waiver programs in Vermont. And so, you know, they sort of thought that perhaps the SASH program was stepping on their toes. And really what has happened is, as they've partnered, and actually in many cases, as I said, they are the contract, they actually provide through contract many of the nurses who are working as part of the teams. These agencies at the local level have really developed relationships with housing, and they understand now that when they are able to go in and manage multiple people at the same time, look in people's refrigerators, see what's really going on, and then be able to rely on the service coordinators once they leave to actually do the follow-up, it's really turned out to be really a fabulous collaboration. So, you know, I think it's one of these things where all of our providers, including home health, tends to work in silos, and how we think about breaking down those silos, some of that, of course, is going to be broken down for us through payment reform and delivery reform. But the truth is that most of the more innovative work is being done by providers themselves at the community level.
Wonderful, wonderful. We do have a question for you, and see if you're able to let us know. Can you tell us the name of the Portland, Oregon group, and is it the Northwest Pilot Project, as she's asking?
Yes,
and thanks, Jennifer.
Yes, I think that is the name of it. Howard Klenk is the managing director. It grew out of Cedars-Sinai, which is an aging services organization in Portland that came together with one of the CCOs in Portland. I'm actually blanking on it. It's a Medicaid MCO in Portland, and then together with 2 mental health clinics, the Area Agency on Aging, and a number of other organizations. And the LLC model is what is so interesting, because it really, everybody has put some money into this game, and then the state is also putting some money in. So there's a real investment in terms of figuring out how they collaborate together.
Great, thank you very much. All right, if you have any other questions, go ahead. We're going to go ahead. The last several slides, we're going to move through those quickly because they're just resource slides for you. So the first is, I talked a little bit earlier about the Maslow's hierarchy. We actually have within the underserved population best practice intervention package, which is that large primary BPIP, lots of great information on all types of issues, but I actually identified housing issue pages for you. There is even information on related to home health aides and information on housing that's included, but that Maslow's hierarchy, the patient basic needs education session, if that's something you really think that you need to bring to light, we actually have a recorded webinar. We have PowerPoint with speaker notes, as well as a clinician post-test and answer key related to those topics that are all related, that are all attached with the underserved population best practice intervention package. And the next slide. And what I did here on the next few slides is kind of pulled together some additional resources that you may need. Here's some information from the HUD. I found a couple specific sites related to Native American programs for you. The next slide, please, Misty. And we have eldercare.gov also provides some additional resources. Plus, I absolutely want you to check out Robyn's site as well, LeadingAge. I was able to find great articles and information there about housing and future housing issues. And the next slide, please. And AARP has information, and I don't know if any of you were able to listen to the White House Conference on Aging that occurred last Monday. It was excellent, and actually Robyn was there personally. But there are some of the recordings are up and some resources. I'm hoping they'll put more of the sessions up, but it was excellent on caregiving to elder issues and being able to stay in the community, all the way to elder abuse. I mean, it was a wonderful day's worth of programs. So keep watching. We'll keep updating in our e-newsletters as new things are posted there as well. And the next slide is just ways that you can connect with us, as usual, through our social media. And our last slide, I believe, is just our thank you. And I don't see any additional questions. You will be sent to an evaluation afterwards, so we really appreciate your comments. Robyn, any last comment you'd like to make?
Not really, other than, I hope that people will see this as a sign of how do we figure out how to look at our senior housing properties in a different way. For those of you who may already have clients there, how do you work more closely formally rather than just on an ad hoc way? And if you don't have a relationship, how do you start to develop one? Because I think there's going to be a lot of opportunities and even business opportunities over the next few years.
I do too. Very, very good. Well, thank you so much, Robyn. This was very, very informative and exciting to help create and to look for solutions to problems and barriers that we're currently having and those that we will have. I think a really great opportunities for home health to be partners and to work collaboratively with many different associations working on this problem. We thank you for all the work you do with LeadingAge, and we thank each of you for joining us today. Do look for in the upcoming e-communications on the next session, which will be in 3 months. So we thank you very much for participating today.